Hi, it's Dr. Kathy Miller from Indiana University. One of my favorite old-time sayings is that the brakes are a really useful tool to have when the bandwagon comes to town. There is no question the minimal residual disease surveillance bandwagon is coming to a town near you. It's not already there. My problem with ctDNA testing is that we don't yet know if it has clinical utility. Now, before you write me off as a Luddite, let me assure you that's not the case. I spend most of my time doing research, including some in this area. I think these new technologies have incredible power, but they also bring with them real dangers. Now, what do I mean by clinical utility? Well, a test has to have several features to be useful. Analytic validity. If you measured the same sample on Monday or Tuesday, or in the same lab, would you get the same results? In this case, we generally do. Biologic validity. Is it measuring something important? Might tell us about the biology. Absolutely, no question. Clinical validity. Does the test put people in different groups that behave differently? Does it identify patients who have a different prognosis, who have a higher or lower risk of disease recurrence? Absolutely. But clinical utility is different. Clinical utility says if you treat patients based on the test or with knowledge of the test, is their outcome differently than if you didn't have the test, if you didn't have that information? That's the problem. For a diagnostic test, clinical utility is based both on the performance of the test, but on our ability to have therapies that will change the outcome. And unfortunately, right now, we don't have those therapies and we don't have that data. So put yourself in this situation. You're a patient. Your physician orders this test, and it suggests you have a high risk of recurrence of your cancer. That leads to additional imaging that you otherwise wouldn't have had. Data says that in a not small proportion of patients, that additional imaging is normal. Well, you're now more terrified than you were. What do you do? Should your oncologist give you additional chemotherapy? Should they change your treatment? We simply don't know. So stop and think about it. For that patient, did you help her or did you hurt her? I hope that these tests will have clinical utility. There are some clinical trials coming that will test clinical utility. But until they do, they're not going to find their way in my routine practice. But I will happily join those trials because that information is critical to advancing the field. It's critical to really helping our patients. Love your thoughts on this as well.